Good afternoon, everyone. So today we'll be continuing our discussion on mandibular fractures from last class. So last class we had talked about the various kinds of mandibular fractures, the classification, the etiology, and the incidence and the incidence of mandibular fractures. So today we'll be coming to how we diagnose and treat the mandibular fractures. Okay. So with as in with any other in medical diagnosis, we start with a history, physical examination, and examination of radiographs, and finally coming to a diagnosis. So an organized systemic evaluation of the facial trauma is required for an accurate diagnosis and treatment planning. So the ATLS protocol provides an excellent framework for this evaluation of the patient with trauma. So once a patient comes to you, they come to the casualty of the hospital or the dental clinic with a history of trauma. First is the ATL protocol, so that the airway breathing circulation is assessed and managed accurately. So in the secondary survey of the ATLS protocol, we go into skeletal examination, and that is where the facial fractures come into play. Now, what we should know is in case of mandible fractures, a bilateral mandible fracture, parasymphysis fracture, can cause gagging of the anterior segment. That means the patient can have a tongue fall and there can be airway issues. So this has to be kept in mind. Now let's come into the history part. Okay, so an accurate history is the first step. Now we have to focus this information on mechanism of injury, previous facial trauma, history of TMJ disorders, and pre-injury occlusion. Now we'll come to each of these in detail. Mechanism of injury means how the accident or the fracture has occurred. So what you asked, why you asked this is, I told you the fracture, mandibular fracture most commonly occurs in road traffic accidents or in interpersonal assaults, in sports injury. So how the fracture has occurred will help us in the diagnosis. So the magnitude and the direction of the force to the patient should be assessed. You should ask how they fell or where the face was hit. If it was on the chin, on the side of the face, or head-on collision. So this will determine what kind of fracture the patient can have. So a direct blow to the chin can be a symphysis fracture. A blow at the parasymphysis can directly cause a parasymphysis fracture, or maybe it can cause an indirect fracture. That is, at the if you have a right-sided trauma in the parasymphysis region, that can cause a fracture in the opposite side angle of the temporomandibular joint. Now, the history of TMJ disorders. Why do we need to know the history of temporomandibular disorders? Is most mandibular fractures are treated with maxillomandibular fixation. That means immobilizing the mandible for a certain period of time. So, a patient with a pre-existing temporomandibular disorder may find this very difficult because there can be atrophy of the muscle, there can be condylar thinning, hypomobility, which can worsen their TMJ disorder, and rigid fixation is considered better in this group. Now coming to the signs and symptoms of fracture. Now the first sign that the patient can tell you is pain. The patient can have severe pain with movement of the mandible, like talking or swallowing. Patient can have a swelling or a bruising in the fracture site. Patient can have bleeding from the periodontium. Also, in anterior mandible fractures or the body fractures, patient can have a sublingual hematoma. Patient can have drooling. They can have altered bite, or the occlusion may change. High mobility of the fracture segment with a palpable crepitus, numbness of the lower lip, trismus or difficulty in moving the joint, loosening of teeth. And in medial displacement of the condyle, patient can have a facial nerve paralysis. If the patient can have facial nerve palsy, and if in case of a direct blow to the ramus region, patient can have a direct facial nerve injury. Okay. So next we'll come into the radiographic examination. So you know that the patient has pain or swelling or hypomobility. So you take an X-ray and see where the fracture is. Now, in general X-rays, we can take a PA mandible, or a PF face, or a lateral face X-ray. But due to the teeth, most often these fractures are not very clear in facial X-rays. So we take orthopantomograph or OPG. So in this OPG, here you can see that there is a fracture on the right-sided angle region. Okay, so the angle has a fracture, and if you look closely, you can see that there is a fracture also on the opposite side condyle. Okay, so there will be a displacement, mild displacement. So the magnitude of the displacement should be assessed. You should see if it is a monocortical or a bicortical fracture. So I'll show you some cases in which we see a mandible fracture. So in this OPG, you can see that there is a fracture in the parasymphysis region, the body region of the mandible on the right side. This is a minimally displaced fracture. Now this is a CT that shows fracture of the symphysis and the body. So there are two fractures on this mandible. So CT is what you take in case of if you have a hospital setup, you need to know the magnitude of displacement of the fracture. So you go for a 3D CT, or a CBCT will also suffice. Now OPG and CBCT are not very widely available everywhere. So CT can be done in hospitals. So if you see this, you see that the fractured segment has moved a bit medially towards the midline of the patient, and this can cause occlusive deficiencies. In the 3D, you can more appreciate that there is a fracture in the dentulous segment. There are two fractures which are displaced. Now this is a clinical picture of the fracture. So you can see the parasymphysis region, there is a displaced fracture. Okay. Now the first picture here, this is showing a comminuted fracture. That is an open comminuted fracture of the lower border of mandible, and this is the same fracture intraorally. So there are multiple fractures. In such cases, what happens is, if the periosteum attachment is completely lost, this fracture segment can go for necrosis. Now, any bone fragment with periosteum attached, you can actually retain. Now, coming to the basic principles of fracture management. So, adequate reduction of the fractures is required. That means the mandible should go into its original shape and position. And we need adequate stability during the healing process of the fracture. The bones should not move. And restoration of the pre-injury occlusion. Because whatever we do for treatment, the patient has to open their mouth, chew. So for that, patient needs a full movement of the mandible, and they need a good occlusion. So that is what objectively the patient needs after your treatment. So that is very important. And restoration of the mandible traction, again, patient should be able to open, close the mouth, speak well. So that needs to be restored. Now, avoidance of any complication, that is infection, malunion, non-union, and any nerve injury should be avoided. Now, the treatment of mandible fractures, with all the possible factors and the implication considered, treatment of mandible fracture can either be open or closed. So we'll come to the closed reduction first. So again, fracture reduction in any bone is separated into closed and open reduction. Now, closed reduction means there is direct interdental wiring, wherein you wire the teeth in order to stabilize the fracture segment. There is continuous or multiple loop wiring, arch bars, cap splints, gunning splints that is used in edentulous patients, and pin fixation. So in these cases, you are not actually exposing the fracture. You are indirectly reducing the fracture. So in open reduction, you put an incision, you open up the fracture, and you can put a transosseous wiring, you can put a plate, you can put a rigid or a semi-rigid fixation, you can do intramedullary pinning, you can use a titanium mesh. If there is bone loss or there is a defect, you can use a titanium mesh. You can have circumferential straps, bone clamps, plates, and screws. Now, after reduction, the patient needs immobilization. That means during the first introduction, what we are doing is we are bringing the two bone fragments into its original position. Then immobilization, so that without moving, the bone can heal.